In this video, I'm going to cover a common question and scenario that arises among some of our practices here in the United States. And that involves ER call coverage and calls from outlying hospitals, EMTALA, and medical legal liability. For those of you who don't know me, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group. I'm answering a question that came in anonymously today, and it reads something like this. Outside emergency department call coverage. Question for the group. How do you handle calls, if you do, from outside EDs? Specifically, if your hospital has no beds available and you cannot accept the patient for a transfer, do you accept calls from outside EDs for advice recommendations? Our group gets an inordinate amount of calls from small outside EDs, mostly for advice recommendations on patient care. The hospital our group covers is frequently full and cannot accept any patients. Are we obligated to accept these calls? We are given a lot of pushback if we refuse and are told that we could be in violation of EMTALA. From my understanding, EMTALA does not apply as we cannot accept the patient and we have no obligation to the patient. I can understand accepting a call for a transfer if there's an open bed or a call from an outside ED for one of your established patients. Just curious how others respond. Our main concern is the liability from giving advice, having that advice documented in the EMR in the emergency department without the opportunity to see and evaluate that patient, let alone the lack of compensation for the advice. Any thoughts or advice on how to respond to this situation? Boy, that's kind of difficult, right? I'm assuming that you are on call at the ER, the hospital, the large hospital that you cover, meaning you have an obligation to take the incoming patients to that particular hospital, which I think it's true in the situation that you described. So if your hospital has the ability to take that patient and you have an outside hospital trying to transfer, it's probably a good idea to answer those calls to determine whether or not a transfer is necessary or the patient may be seen, if the patient may be seen as an outpatient. In that situation, obviously, you definitely want to document every single phone call that you take from that outside hospital, because guess what? Any time that you get on the phone, give advice over the phone to an ER, heck, it could be a bedside or curbside consultation or another physician in the hospital asking you about a particular patient, that constitutes an interaction and you may be liable for giving that advice. Believe it or not, that is true. Okay? So anytime you give advice over the phone to an ED, you definitely want to document with whom you've spoken, the name of the patient, and document that in your EHR or somewhere where you can reference back to cover your behind from a medical legal perspective. So the other thing that you want to consider is if you have outlying hospitals that are not within your state and you're not licensed to practice in those outlying hospitals, giving medical advice is like you treating the patient across state lines. So, of course, you can do that, but you may be practicing medicine without a license in that state. Also, your medical malpractice carrier may not cover you in case of an untoward event or a claim against you if that claim arose from your interaction with that patient's doctor in that ER at the outside facility. So always keep that in mind. Document every interaction that you have with a patient or someone asking about a patient. Now, the scenario that you described is that your hospital, maybe that hospital has a relationship with the outlying hospital. That outlying hospital, I'm assuming, has no urology coverage and wants to transfer the patient whom they think is an emergency to your hospital. And yet your hospital has no beds and has reached critical capacity and has no ability to take care of the patient, even if you wanted to. So in that case, again, you probably want to take the phone call and speak with the outside facility and let them know that you have no ability to take care of the patient due to the situation in your hospital. It could be a flood or some sort of a physical plant emergency, which renders your ability to take care of that patient an impossibility. It doesn't matter what it is. It could be a bed situation like what is happening now with our current pandemic, or it could be some sort of a physical problem with the structure of the ER, OR, or the hospital. It doesn't matter. If you don't have the ability to take care of the patient, you definitely want to let them know that, hey, transferring here is not going to work. So don't even bother. Call the next closest facility and transfer that patient. So that's how you handle those calls and mitigate medical liability. When it comes to EMTALA, it is important to understand what that means. EMTALA covers and applies to hospital ERs. It does not apply to physicians. I'll say that again. It applies to hospital ERs and it does not apply to physicians. It basically prevents hospital dumping of non-paying, poor-paying patients to another facility. So in the situation that you're talking about, the outlying hospital probably has a critical patient or a patient that needs to be treated and is trying to transfer the patient to your facility, and you are full. You can't take care of that patient. So in that case, you would advise the outlying hospital and obviously document that in your chart, in your EHR, wherever. Let them know that you have no ability to take care of the patient and you're going to have to decline the transfer. And you would advise the hospital or the ER doctor at the outlying hospital to transfer to somewhere else that can take care of the patient. Unfortunately, that may mean flying that patient somewhere due to the distance where the next available facility is located. So unfortunately, you probably would need to talk to that outside facility and let them know what's going on so that they can appropriately document in their chart and cover their butts and also disposition that patient in the most expeditious and safe manner possible. So that is how I would personally handle that situation. I know you are in a large hospital. It's kind of like catching all the outlying hospitals' traffic, but it is important to cover yourself medical legally, make sure you're practicing responsibly, and also CYA, right? All right. Any questions, comments, suggestions, oppositions, rebuttals? Leave them in the comments below. Take care.